Would be all protocols duly observed. In the next 15 minutes, I'll be discussing septoplasty. The nasal septal deformities can be cartilaginous, bony, or both. There are various types of septal deviation, which include deviations, which include caudal dislocation, C-shape deformity, S-shape deformity, septal spur, thickening of the nasal septum, and crooked nasal septum. All these can be treated with septoplasty. Septoplasty is a surgical or a corrective surgical procedure done to strengthen a deviated nasal septum. The procedure can be endonasal, endoscopic, or external. The septum gives a structural foundation to the external nose. It consists of three components: the membranous, the cartilaginous, and the bony component. The membranous component forms the most anterior part of the nasal septum. The cartilaginous component is quadrangular in shape. Inferiorly is attached to the maxillary crest. Superiorly is attached to the upper lateral cartilage. And behind it is attached to the perpendicular plate of ethmoid and the posterior superior aspect, and to the vomer and the posterior inferior aspect. There are two surgically critical points of articulation on the nasal septum. At the junction of the anterior nasal spine of the maxilla and the keystone area, which is the junction between the upper lateral cartilage, the septal cartilage, the perpendicular plate of ethmoid, and the nasal bone. These articulations give stability to the nasal septum, and this should be preserved during septoplasty. The septum is covered with mucoperichondrium and the septal cartilage, and mucoperiosteum and the bony septum. And this is just the brief anatomy of the septal cartilage. Indication for septoplasty. Septal deviation causing nasal obstruction. Septal deviation causing recurrent epistaxis, especially from the septal spur. Septal deviation causing obstructive sleep apnea and Slaughter syndrome. And septoplasty may be part of functional endoscopic sinus surgery. Contraindications for septoplasty include rhinosinusitis, vasculitis, uncorrectable coagulopathies, active recreational drugs such as intranasal cocaine. Patient with unrealistic expectation is a strong contraindication for septoplasty. Detailed history, including the extent and nature of nasal symptoms, history of allergies and prolonged use of typical decongestant, previous history of surgeries is very important because there will be a risk of flap tear during septoplasty because of fibrosis. Full head and neck examination, examine the external nose for any deformities, and examine for degree of collapse of the ala during moderate or forced inspiration. A positive cultural maneuver usually indicates there is internal valve stenosis. Anterior rhinoscopy is done to describe the site, the type, and the extent of septal division. It also detects other nasal pathology that may cause a nasal obstruction. Palpate the caudal septum for thickness, strength, and orientation. Nasal endoscopy may be done if there's other nasal pathology that may cause nasal obstruction. Imaging is not routinely done to evaluate patients with deviating nasal septum, except if there are other nasal pathologies. Pre-operative counseling consent is also very important regarding the procedure, the risk and complication of septoplasty. Patients should discontinue antiplatelet medication because of risk of perioperative bleeding. And patients should also discontinue the use of intranasal cocaine for at least 6 months. These are the instruments needed for septoplasty, and the ones highlighted in red are most essential. Septoplasty can be done under local or general anesthesia. General anesthesia is more preferable because it maximizes patient comfort and also optimizes airway protection. For a patient undergoing general anesthesia, throat should be packed with wet gauze. A patient plays supine with the head elevated to about 20 to 30 degrees, head up, the eyes dipped, a patient draped, exposing the face from the eyebrow to the upper lip. A patient is assessed again using Killian's speculum to reassess the preoperative findings. The septum is infiltrated with 2% xylocaine with 1 in 100,000 adrenaline using dental syringe. Usually the injection should be done at the subpericordial and subperiosteal plane. The nose is decongested with oxymetazoline soap plated, which is left for about 5 to 10 minutes. There are various incisions used for approaching nasal septum. Killian's incision is usually made about 1 to 2 centimeters behind the caudal border of the caudal border of the nasal septum. It is indicated when deviation is located in the middle or posterior 1/3 of the nasal septum. The disadvantage of this type of incision is that there's difficulty in assessing caudal deviations. Hedged incision is usually done at the mucocutaneous junction of the nasal cavity. The more commonly used incision is the Freer's hemitransfusion incision, which is usually done along the caudal border of the nasal septum. It can be partial, full, or extended incision. That is when incision is extended along the floor of the nasal cavity to assess septal spore. This diagram is just showing where the incisions are placed. Now, to make a Freer's incision, which is more common, Killian's speculum is used to stabilize the vestibular skin and the septal mucosa. This make the caudal border of the septum to be prominent. Number 15 blade is used to make a vertical incision on the caudal margin of the septal of the nasal septum. Once a shiny bluish tinge of septal cartilage is seen, it means that you are in the right plane. You are in the subpericordial plane. Now, using the Killian speculum and Freer's elevator, now 3 turns are made in order to elevate the septum from the flap from the septum. The anterior tunneling means you are elevating the flap from the septal cartilage. Inferior tunneling is elevating the flap along the anterior nasal spine and maxillary crest, and posterior tunneling is removing flap, elevating flap from the bony septum. Once the flap is fully elevated from the nasal septum, the septal cartilage is dislocated from the perpendicular plate of ethmoid and vomer. And this articulation is also done at the maxillary crest inferiorly. It's very important at this stage. It is very important when dislocating the septal cartilage from the maxillary crest. It's important to leave to be sure that the attachment to the anterior nasal spine of the maxilla is intact, so as to maintain the stability of the nasal septum. Now, the mucoperiosteal flap is elevated over the bony septum on the opposite side after dislocating the septal cartilage from the perpendicular plate of ethmoid and the vomer. Once the bony septum is free from this flap and is deviated, then the deviated part of the septum is removed using a special instrument called Jensen-Middleton forceps. It's a special forceps in that when you try to remove the deviated segment, it does not twist, unlike when you improvise using Lux forceps. So the risk of fracture of the cribriform plate causing CSF granulia is minimized. Likewise, the bony spurs causing nasal obstruction is also removed using the same instrument. Now, for corrections of cartilaginous deformity, depend on the type of deformities. If assuming it's a dislocated septal cartilage, first is to excise a small wedge-shaped cartilage at the lower part, the lower part of the septal cartilage. This allows the septum to move to the midline at the anterior nasal spine, and they use suture to stabilize the septum over the anterior nasal spine. For angulated caudal septum, is to divide the apex, the overlapped end are sutured together, or you can excise the overlapped end, suture them together, and reinforce with a biting graft. Now, for C or S-shaped deformity, you can treat this kind of deformity using what we call a cutting technique or scoring of the septal cartilage. This involves making multiple horizontal incision on the concave side of the deflated of the deviated segment, or making a small wedge-shaped incision also on the deviated concave side of the septal cartilage. This tends to weaken the tensile strength of the cartilage so that it can easily be amenable to retain the straight configuration. And this can be reinforced using what we call a spreader graft, or can be split. Now, after correcting the deformities, it is very important to reassess the septum for any residual deformity, to check mucoperiosteal flap for whether it's intact, whether the tip support is adequate. If all are okay, then the incisions can be closed with 4O vicryl. Quilting suturing are done to prevent post-operative hematoma. Nasal stent are inserted. A nasal pack is not necessary except if there was a perioperative bleeding. Then you can pack the nose to provide hemostasis. Septoplasty is a day surgery, and the patient can be discharged on the same day with antibiotic and analgesic. If there's any turbinate congestion, oxymetazoline can be given to decongest the node. Patient is followed between 1 to 2 weeks. Then after the patient can Patient can be assessed post-operatively and stent removed. Complications include excessive post-operative bleeding, septal hematoma, sinusitis, septal perforation, CSF leak, toxic shock syndrome for patient with nasal not on antibiotic. Sometimes need for revision surgery may occur. My references. Thank you for listening.